Good morning, everyone, and welcome to this morning's web seminar on SB 245, authored by Senator Connie Leyva, Decreasing the Rate of Unintended Pregnancy Among Youth in Foster Care. My name is Amy Lemley, and I first want to start by thanking everyone for taking the time to be on today's webinar. The purpose of today's webinar is to really provide the evidence supporting the provisions of Senate Bill 245, to go into a detailed description of the provisions of Senate Bill 245, and also to provide an opportunity for you to ask questions and to offer your opinions. And so thank you for being here, and without further ado, let's jump right in. Joining me today, first will be Sue Abrams of the Children's Law Center of California. She'll be followed by Alexis Berries. Alexis is a former foster youth and also a member of the Healthy Sexual Work Group, which was convened by the California Department of Social Services. Following Alexis will be Rebecca Goodman of the National Center for Youth Law. So we're looking forward to hearing from each of you, and thank you very much for taking the time to be on today's web seminar. We'll collectively be discussing the reproductive realities of California foster youth, followed by the 4 provisions of Senate Bill 45. We'll then talk about how you can get engaged with this important legislation in whatever capacity you are involved, and then we'll follow that with questions and answers. So that should take us about an hour, and here we go. Before we jump into the content of the bill, however, I do want to take a moment to acknowledge and introduce our author, Senator Connie Leyva. So Senator Leyva represents the 20th District in the California State Senate, known as the Inland Empire. Some of the kind of larger towns and cities are Chino and San Bernardino. And Senator Leyva has an extremely distinguished track record of legislation that is serving California's most vulnerable. You can see on the slide some of her legislation has assisted rape victims, domestic workers, homeless students, crime victims, just amazing work in her time in the Senate, and we are extremely appreciative that Senator Leyva has really taken up the issue of reducing the rate of unintended pregnancy among former foster youth. So thank you very much, Senator Leyva, and we're looking forward to going on this journey together with you. So why are we today talking about sex and unplanned pregnancy? It seems a little bit incongruous, for around the issue of foster care. Kids in foster care are young, right? Why are we talking about sex? Well, the reality is, and as we emphasize a lot in our organization, the demographics of foster care have changed considerably. Most young people in foster care are no longer small children. And in fact, 1 in 4 young people in foster care in California is age 16 and over. And so the realities of our foster care population have changed. The experiences they're having, the challenges they're facing are changing. And one of them is unplanned pregnancy. So you see on the slide before you, we now have information about the rates of pregnancy among youth in foster care for the first time. And this is really due to the Cal Youth Study, which is led by Professor Mark Courtney at the University of Chicago. It's a very important study that I turn to time and time again. It yields so much wonderful information about our older youth in foster care. And it did help us understand that by age 17, over a quarter of young women in foster care have been pregnant at least once. 1 in 5 of those young women in foster care have been pregnant 2 or more times. So as you can see, that is more than double the rate of the same age general population, which really gives pause. Often when an effect is 15% greater or 20% greater, this is 200% greater than the general population. By age 19, the rate increases even more, almost half, just 0.7 points shy of half have been pregnant by age 19. As compared to only 20% in the general population. So the rate of disproportionate pregnancy is heightening as young people get older. And again, about 1 in 5 have been pregnant 2 or more times. So this really causes us to step back and to say, you know, are we doing what we need to be doing to try and prevent these high rates of pregnancy? Not coincidentally, you know, high rates of pregnancy lead to high rates of childbearing. And so this is the absolutely, you know, spectacular research conducted by Emily Putnam-Hornstein and her colleagues at the University of Southern California in conjunction with the University of California. And it, again, was the first time that we had the definitive information that linked child welfare records with birth records. And this is the childbearing rate of young people who are in care at age 18. So you can see that by age 21 of young people who are in care at 18, over a third have had their first birth. And, you know, so the question is what are the implications of that? What does that mean for these young people? What does it mean for their young children? And as you can see in the box on the screen, there's also the issue of a repeat birth. So of young people who truly have a teen birth, you know, who give birth before age 18, 1 in 3 will have a second birth. So it's a, you know, the statistics were a little bit foggy in the past. You know, we didn't have this research, we didn't have the CalU study, but in the last couple of years, this issue has really come into focus, and we have the evidence we need to get a clearer picture of what's going on. Now, of course, those of you who are social workers and probation officers and case managers and dependency attorneys, you've seen this in the field for a long time. But in order to, you know, change public policy, we have to go beyond the anecdote and know that this is a larger systematic problem. However, when we talk about these high rates of pregnancy and these high rates of childbearing, a response that we often get is, but don't these young people want to become parents? Don't they want to have children? A very common narrative among some is that, you know, foster youth have experienced abuse and neglect, they've been removed from their families, and they have children and become pregnant because they want to replicate the family they never had. That's kind of the story that we hear. But again, if we turn to the CalU study, we can see that that narrative just doesn't prove out. The CalU study asked the young people who became pregnant or young men who impregnated a woman and said, you know, did you want to become pregnant? Did you want your partner to become pregnant? And certainly, as you can see from the bottom of that table, a little over 1 in 4, the answer is yeah, I did definitely want to become pregnant. But that is not the most common scenario. The more common scenario is the combination of definitely no, probably no, or somewhat ambivalent, neither wanted nor didn't want. So if we know anywhere from 40 to 60% of young people who are becoming pregnant or who are impregnating a young person do not want to become pregnant, the question is, what are we going to do about it? What can we do to help these young people have access to the reproductive health care that they need to make the choices that they want to make about their futures and the future of their children? So I guess one question is, so why do foster youth experience these high rates of pregnancy? In some ways it may seem obvious, right? I mean, but the reality is there's a very unique set of circumstances facing foster youth, and that unique set of circumstances is what SB 245 is really trying to address. So starting that far left-hand corner, foster youth were reported more than twice as less likely to use no contraception during intercourse in the last year. This is a question that the CalU study asked of our 19-year-olds, and it's also a question that's asked in a general population survey of 19-year-olds. So we're really able to compare apples to apples here. And young people who are 19-year-olds in foster care in California are more than twice as likely to report that during the last year, while being sexually active, they use no contraception. So that really raises the question, do they know about contraception? Do they have access to it? Why are they using it at rates at much less frequently when they're reporting that they do not intend to get pregnant? So there's a real lack of knowledge about contraception and a lack of access to contraception. Now moving over to the right around confusion about reproductive rights, we also, you know, with this changing demographic, this aging demographic, we haven't really done as well as we could have done to ensure that the child welfare workforce is supported and that they know about what the kind of rights and responsibilities around reproductive health are. Later in the presentation, Rebecca's going to go into more depth about this survey. But child welfare workers in California were surveyed, and the overwhelming conclusion is they do not feel that they have the information or the materials to properly address this highly sensitive topic. Just a third of child welfare workers felt that they were adequately trained. And without the training, we're really setting up our child welfare personnel to not do the jobs that they want to be able to do. Down to inconsistent access to sexual health education. Another question might be, well, isn't this covered in the schools? And again, there's a lot of reasons why foster youth are not getting that access to comprehensive sexual health. School and placement instability, attendance at non-public schools, and waivers that foster parents can make due to religious reasons. And again, Rebecca's going to go into these in more depth, but the fact is that many foster youth are not in that school seat when comprehensive sexual health is being addressed. And then finally, while I don't think this happens, tremendously, we do have instances where we know that information and access to reproductive health is actively being restricted for foster youth. And on the slide you have a lawsuit, California Planned Parenthood versus Promesa Behavioral Health. And we had practices in that case where young people were signing paperwork, promising to avoid participating in any sexual activity. Contraception, including condoms, were being confiscated. So again, I'm not characterizing this as happening broadly, but it does happen. And so these are some of the reasons why we're seeing, the high rates of unplanned pregnancy. And so these are the things that we want to get to. We want to change with SB 245 so we can bring down that rate of unplanned pregnancy. And the implications are extremely serious, both for young people and for their children. So educationally, again, we know from that Cal Youth study that we go back to over and over again, young people in foster care have very high academic aspirations. They want to go to college. They want to go to graduate school. However, at age 19, of those who had not enrolled in higher education, 1 in 3 cited the need to care for children as a major barrier returning to school. Now, we could have put 20 more different pieces of evidence on this slide that demonstrates the relationship between low educational achievement and early childbearing. The National Campaign to Prevent Teen and Unplanned Pregnancy found that if you have a child during community college, there's a 60% chance you will drop out. So for our young people who have such high aspirational goals in post-secondary education, giving them the opportunity to not become a parent is essential. Otherwise, it slows or dramatically hampers their ability to achieve those degrees or technical certifications and move out of a minimum wage situation into a living wage situation. And that really relates to the second one. Again, economically, it's a tremendously more difficult once a young person becomes a parent. We all know this in our own lives, the complications and costs that come with child care, but for young people who have a much more limited support network, less education, the challenge is even greater. And then the third item on this slide is the children of young people who have a substantiated report of maltreatment. This is another study that is thanks to Emily Putnam-Hornstein at the University of Southern California. It looked at, of young people who were in foster care who themselves had a substantiated report of maltreatment, what is the likelihood that their own child would by age 5? And they were 3 times more likely by age 5 to have a substantiated report of maltreatment. Now, what's important to note here is that that doesn't mean that their parent maltreated them. There's a lot of, kind of reasons and explanations around this. But in some ways, we shouldn't be surprised because our system is not fully designed to support and protect young families in the way that it could. And so given this disproportionate rate of the risk of maltreatment among the children of dependents, certainly for young people who do not want to become pregnant, we want to give them that opportunity. So that's some of the, kind of most relevant California-specific evidence around the issue of unintended pregnancy among former foster youth. I now want to hand it over to someone whose organization serves thousands of young people in the field every day and can really paint that picture of what it looks like. So thank you very much, Sue Abrams from the Children's Law Center, for being on today's webinar.
Thank you, Amy. And just briefly introduce Children's Law Center of California, where I work. We represent 33,000 children in the California foster care system, specifically in Los Angeles, Placer, and Sacramento counties. And what we're seeing kind of on the ground and in our practice is really reflective of the statistics you just covered, just extreme gaps in access to information and services. And we've been, aware of these gaps for many, many years and have done efforts at the local level. But there's still much kind of inconsistencies in the access to information and services. For example, one of our attorneys who represents youth in a specialized court who are victims of commercial sexual exploitation, she reports that her clients generally they seem informed and they're getting access to services because there's been very targeted outreach towards the population of youth she works with. Contrast to that, we have a peer advocate who herself is a former foster youth, and she specifically goes out into the community, into group homes to provide trainings for youth. And what she's seeing is that most of those youth don't even know the basics, even though they're teenagers. Some are even young adults. And so we're just seeing extreme inconsistencies in this access to information and services. And I think, Amy, if you flip to the next slide, there's kind of an overview of what I'm talking about. Some of the factors that play into the inconsistencies are geography. So some counties have policies in place. They've been working many years on the issues, and the youth seem to be getting the information and access to services better than in other counties who are maybe don't have policies in place or are just working to develop policies. Also, placement instability. You talked about this a bit, but for our older youth, we see sometimes some unstable placements and a lot of moving from home to home and school to school, and so there's not really any specific placement that would be ensuring that the youth has access to reproductive health information and services. Also, placement type, and I don't mean this in that foster homes are better than group homes, or it's just that some placements seem to be much more committed to ensuring that their residents or youth who are living in their homes are accessing information and services, and others aren't, and there's a variety of reasons for that. Interestingly, another area where we're seeing some inconsistencies is gender. So the peer advocate who does the trainings reports that in her trainings that the young women seem to be much better informed than the young men, and it may just be that there's been more targeted outreach towards the young women, but there seems to be a difference we're seeing on the ground in information provided to women versus to females versus males. Individual social workers and caregivers, and Amy talked a bit about child welfare workers, but also with caregivers, there's a lot of misinformation. We hear a lot from caregivers and from workers. They don't know whose responsibility it is to provide the information or to ensure the youth have access to services. There's also a fear of liability. They don't know if they can provide that information or if they can make sure the youth is connected to services. And then just some issues specific to foster care where a lot of our caregivers are in a parent role, but they're not the actual parent, so they don't want to overstep. And the end result is that the youth are not getting, the information or the services that they might need. And even if the information and services are accessible, it might not be accessible. It might not be, the communication might not be effective such that youth are actually retaining the information or they know where to go to get services. And why is that? Well, there's general issues with teens getting information around reproductive health. There's social stigma, there's religion issues, there's, the conversations are just uncomfortable. I mean, those are kind of general issues with teens getting reproductive health information and accessing services. And then you have things that are specific to foster care. So a lack of rapport or trust. I mean, there might not be a trusted adult for the youth to talk to. Some of our youth are living in group homes. They don't know who to turn to get the information. What we're hearing a lot is that if you do access reproductive health information or services, that's being driven by the youth. They're seeking it out. But for some youth, they might not feel comfortable, or they might not know who to speak to. And so that lack of rapport or trust can play a big factor into the accessibility of reproductive health information and services. Also, there's concerns about information remaining confidential. So we've had several, comes up very frequently, where youth might request services or request information, and that ends up in a court report where the youth's family might see it, or the judge or attorneys. And so that kind of concern about their confidential information ending up being made public sometimes might stop the youth from seeking out the information or the resources and services. We're also hearing about messaging issues, some cultural sensitivity. So some of our youth are saying that they're, when people are speaking to them about reproductive health, they're coming from a place of youth in foster care shouldn't get pregnant, and there's all these bad outcomes, instead of talking to them about choices and making sure they understand their choices and they understand where to access services. So I think that messaging, comfort in the delivery. So I think, Amy talked about some lack of training for social workers, and I was talking about lack of training for caregivers. That may play out in an uncomfortable, them not being comfortable delivering the information. And if a youth senses that the person delivering the information isn't comfortable, they might withdraw, they might stop the conversation, or not, seek out more information, or go to them if they need access to the services. So really it's, what we want to see more of is youth being empowered around decision making and accessing information and services. And the last thing I want to talk really briefly about is gaps in the continuum. So we're talking now about preventing unplanned pregnancies, but what happens when the youth does get pregnant? There are still gaps after that. So there are gaps in talking to the youth about choices and what options they have when they're pregnant, and then there are gaps in helping the youth if they do have the baby, in making sure that they have all the resources they need to provide a safe and loving home. So I think we're seeing gaps in that entire continuum, and that's very concerning. And now I'm going to turn it over to Alexis Berries.
Thank you for that. Good morning, everyone. My name is Alexis Berries, and I spent 18 years in foster care, including being part of the first cohort to graduate Assembly Bill 12, which was an extension of foster care. I've since been very active in advocate work around the child welfare system. I have been a member of many work groups, including the Healthy Sexual Development Work Group at the state, in which I have been exposed to a lot of insight, as well as being being a sibling to a pregnant and parenting youth. So I want to bring forth a couple things, and I know that it was just touched on, but one being it's the lack of trust. As a foster youth, it can be hard to share and express this sensitive information with anyone, while knowing that everything you say is not only documented, but it will follow you from placement to placement as long as you're in care. It's very uncomfortable knowing that you are judged by what's being documented by people you don't even know and that don't personally know you. Many of the foster youth that I work closely with express to me the discomfort in sharing this information, because unlike traditional homes where your business stays between your immediate families, like a mom, a dad, siblings, while you're in foster care, all this information gets put into a case report and sent off to a judge for everyone to read. There's no privacy, and that's a big issue, is the privacy. I also believe that there's an importance to having earlier education, not waiting until puberty to relay this information or educate youth on sexually healthy development. I remember when I was in group home care, I believe I was around 9 years old, and all the older youth in my group home who were 15 years and older were allowed to go to Planned Parenthood once a week to get the information around reproductive and sexual health. While the group home staff would say, you guys are too young, you're too young for this, you don't need to know, you can't go, you're going to stay here. And so I think that's a bit premature as as many foster youth are being exposed to sexual conduct as early as 7 years old and younger. I mean, if you think about it, youth who are a term called AWOLing, who are leaving the group home, going out when they're introduced to CSEX, sexually exploited, or I'm sorry, sexually commercially exploited behavior, they're coming back into the group home and exposing all the other youth about this. So I strongly believe that age-appropriate education is key in talking with youth at every age. Even if it seems to be a bit uncomfortable, I realize it's an uncomfortable topic, but it still needs to be addressed. That all ties into the right person who's involved in your life being knowledgeable and educated on this. So definitely more defined trainings around that. Lastly, we all have our personal beliefs as to when and if it's okay to have this appropriate talk, what we call the birds and the bees. And I know that many will express the concern that introducing this talk to kids who haven't been exposed yet will make them wonder and go out and be exploited to that. But I can assure you that social media nowadays, the interaction with other kids, having already been exposed in all kind of things, is already out there. And I think that it's important to put your personal beliefs aside, religion, faith, whatever that is, put it aside and address each youth appropriate. It's important that the youth have access to the information so that they can understand. It's important to have it accessible for them. Many youth, like myself, we just need the right education. A lot of us don't realize the hardship it causes to be a parent or around sexual health, and many of us have ambitions and goals, and we fail to meet that. We definitely need to be more empowered to make these choices. So I'm going to now pass it on to Rebecca.
Thanks so much, Alexis. So it's my task now to introduce everyone to the bill. And the goal of SB 245 is to address this this high rate of unplanned pregnancy among youth in foster care. Amy, Sue, and Alexis provided a wonderful context and background about the need and hinted at some of the key components, the framework that we think we might be able to make some change in this area. So our sort of three sub-goals within SB 245 are to ensure access to comprehensive sexual health education, improve access to reproductive health care, and strengthen the knowledge of social workers and caregivers. So in this next section, I'm going to walk you through the four main provisions of the bill. And while they've already provided some context for why we think these three areas are so important to hit, I'd like to go into a little bit more detail and provide a little bit more research so that you can understand the context of the provisions. So next slide, please. So the first provision of the bill addresses the important need for comprehensive sex education. And as context, we're really trying to leverage some important work that's already happened in California. In January 2016, a new law went into effect in California called the California Healthy Youth Act, and that law does two important things. It requires all public schools to make comprehensive sexual health education available at least once in middle school and at least once in high school. And secondly, it provides some very specific content requirements for that, for what that curricula must look like to comply with the law. You can see more information and more detail about the California Healthy Youth Act if you go to California Education Code, but we wanted to just highlight a couple points about the new requirements and what these curricula must look like. So the law requires that all curricula are age appropriate, medically accurate, and objective. It's also required that they're appropriate for use with a diverse range of folks from whatever ethnic or cultural background, for youth with disabilities, for English language learners, and for youth of all races, genders, and sexual orientations. The curricula cannot reflect or promote bias against any person on the basis of any protected category. And it must affirmatively recognize that people have different sexual orientations and provide examples of relationships and couples that are inclusive of same-sex relationships. It also needs to teach pupils about gender and gender expression and explore the harm of negative gender stereotypes. And it also needs to provide pupils with knowledge and skills in order to form healthy relationships based on mutual respect and affection and free from violence. And finally, it needs to provide information about sexual harassment, sexual assault, adolescent relationship abuse, intimate partner violence, and sex trafficking. So that's a lot, but there are curricula out there that do comply with the California Healthy Youth Act, and now all of our public schools in California are adopting these curricula and are implementing these new requirements to make this available in middle school and high school. Next slide, please. But of course, as already alluded to by Sue and Alexis and Amy, we know that even having a curriculum available in school doesn't guarantee that a youth, particularly a foster youth, will be able to access that curriculum. And there's a number of different reasons that have been mentioned. It may be school instability, moving around. You happen to come in to school in the middle of the year after they've just completed the curricula, placement changes that move you from school to school, waivers. It may be that a caregiver or a parent opted you out of this curricula. It may be that you're attending a non-public school. There are a number of different reasons somebody may not be able to access this, even when it is a requirement in our public schools. Next slide. So the first provision of this bill, and it's a pretty basic one, it says, it asks the Child Welfare Agency and tasks them with the responsibility for monitoring whether a youth has received comprehensive sex education in school. So they ask, did you receive comprehensive sexual health education in your school? If the answer is yes, great. The requirement is met and there's no further action required. But if the answer is no, there may well be an obligation for the Child Welfare Agency to refer that youth to a community-based resource that provides similar curricula in the local community. Next slide. The second component of this provision is, so first we ask, have you received education? The second one is a requirement for frequency of education. So for the general population, the California Healthy Youth Act says curriculum must be provided at least once in middle school and at least once in high school. This bill says we want to ensure that foster youth are able to access a similar curricula at least once before age 12, once between ages 12 and 14, twice between ages 15 and 18, and once between ages 19 and 21. Now there are questions, why is there this frequency? Next slide. And there's a number of different reasons that we've added sort of increased frequency for access to this education. First, as Alexis said, we know it's critical to ensure that youth receive puberty education and basic sexual health education before puberty. This bill will ensure that all foster youth are able to receive this information at least once, hopefully, before the likely onset of puberty. Another important component is the unique risk profile. We know that foster youth have higher rates of trauma, higher rates of abuse and sexual assault, and we also know there's a much higher likelihood that they'll face barriers to services and education. We've seen this in the statistics, and we see it play out in some of the statistics you see on this slide. We know that the average age of first intercourse for foster youth is younger than you would see in the general population, that the average number of sexual partners is greater, and that the reported use of contraception is less, and that may be due to many different reasons, as we've already touched on, but we know that this is, for a lot of different reasons, a population of youth with a lot of questions, a lot of need, and and those questions and needs change as we go from age 10 to age 14 to age 15 to age 18. So we want to make sure that there are multiple points to have access to accurate, culturally appropriate, comprehensive sex education. Another important point is the average length of stay. The median length of stay in foster care is actually only 436 days. And so we're not really contemplating that many youth will be touched from age 10 to age 21 with the multiple requirements to obtain comprehensive sexual health education. We're really trying to ensure the schedule is developed to ensure that all youth are able to complete compliant curriculum at least once while they're in foster care. And then finally, as already discussed, thanks to AB 12, we now have many foster youth staying in care to age 21. We know that many questions and risks change as youth get older. SB 245 will ensure that youth do receive access to information during that age period when they're most at risk for unplanned pregnancy, which is ages 18 to 21. Next slide, please. The second provision of the bill is designed to ensure that youth are able to access sexual and reproductive health services. Now, it's important to put in context that there are already many sexual and reproductive health rights that youth have. They have a right to access age-appropriate, medically accurate information on puberty, reproductive and sexual health care, prevention of unplanned pregnancy, and the prevention, diagnosis, and treatment of sexually transmitted infections. They have a right to access confidential sexual and reproductive health services. And they have a number of other rights designed to ensure that there is an open door to information and appropriate sexual and reproductive health care when a youth needs access to those services. In addition, the Child Welfare Agency already under state law has a number of duties, including an obligation on a biannual basis to inform youth about their rights to information and services, and an obligation to ensure youth are not facing barriers to accessing reproductive and sexual health care. And in fact, affirmative duties sometimes to help address those barriers, like supporting transportation to the appropriate health care service if that's what a youth asks for. So what SB 245 would do is ask that the Child Welfare Agency once a year in the case plan, starting when youth are ages 10 and older, document how they're going to address these rights and ensure that youth are not facing barriers to care. We want this documentation to occur on a yearly basis. As youth age, the types of education and services they may need will change, and so revisiting on a yearly basis we think is appropriate because the kinds of referral resources, the kinds of barriers, the kinds of questions will change. Next slide, please. So the next provision is critical because obviously many of the services and supports are connected back to the Child Welfare Agency and the critical trusted adults in a foster youth life, helping facilitate access to information and to services. And so the third prong of this bill tries to address and support the Child Welfare Agency, the social workers, and the caregivers who have flagged that they need more support. So Amy already alluded in a broad way to this study, but we wanted to provide a little bit more information about a study that was conducted by Professor Norm Constantine and his team from UC Berkeley and the Public Health Institute. In 2009, they went out and did some in-depth research in 4 different counties, asking the critical question, what are the barriers to sexual and reproductive health care for foster youth? And in their interviews with social workers, what many social workers flagged is that there was simply no training for them on the reproductive rights of youth, their respective obligations to connect youth with services, or on the services and education available in the community. Many said that they received no training on how to have conversations, how to even open up the topic in a way that felt comfortable for them and for the youth. As Sue flagged, creating that trusting rapport is critical if you're going to have these kinds of conversations. In many counties, there either was no county policy or protocol or very unclear county policy or protocol to describe the duties and roles that a caregiver or a caseworker is expected to take. Just quickly, 2 quotes from social workers from that study. One said, in our county, there are actually policies that prohibit early discussion of sexuality issues with children and adolescents, and this is a significant barrier to services and resources. Another said, it goes back to what the department says I can talk about. I don't know how far we can go into a conversation, and so I avoid certain topics. Before we identify ourselves as a resource, we need to put in some serious training and serious protocols if we're going to do this. And finally, one more said, I would need it to be clear what we can discuss and what the boundaries are. Most of us probably feel comfortable, but we don't know what we are allowed to do. Next slide, please. So Norm's study, which you can look up, and we'll have the citations at the end of the presentation, provides a rich amount of information and resources suggesting that we need more support, more training, more protocol. But this is still, but this was 2009. This is still a burning issue. In 2014-2015, the John Burton Foundation, along with others, sponsored what was called the California Foster Youth Pregnancy Prevention Institute. And as part of the institute, 6 different counties voluntarily enrolled, and in exchange, the institute provided a lot of education, technical assistance, and support as these counties worked to develop new policies and protocols around sexual and reproductive health care services and information, and to adopt new strategies in their counties. As part of the educational process in the institute, many questions came to light. Many social workers trying to understand what their role is, and some of the questions you see up on this slide come straight from that institute. Really concrete, specific questions. Does a foster youth need a court order to get an IUD? Am I required to provide transportation for a youth to get an abortion? Am I allowed to provide transportation? How do I talk to youth about sensitive topics? What do I document in the file? As a caregiver, am I required to store a youth's birth control or condoms? Am I required to tell a social worker if my foster youth is having sex? So a lot of really concrete, basic questions, and folks looking for guidance and specific answers. Next slide, please. Knowing that there was a need for more specific support and guidance, actually the California Department of Social Services convened what was called the Healthy Sexual Development Work Group in 2016. The work group comprised both public and private agencies and experts who came together to look at what the needs were, and ultimately the goal of the work group was to develop what was called, ultimately called California's Plan to Prevent Unintended Pregnancy for Youth and Non-Minor Dependents in Foster Care, and you'll see that listed. It was ultimately issued by the department as part of All County Letter 16-88. The plan is designed to lay out a framework that addresses both the obligations of the child welfare agencies and caregivers, and frame out some of the recommendations for what a training might look like, what are some of the resources available. In conjunction with the issuance of this plan, CDSS also issued an all-county letter 16-82, which summarizes the reproductive and sexual health care rights of youth and non-minor dependents, and issued some guidance for residential facilities and resource families on how to support the healthy sexual development of foster youth. And part of that guidance both lays out the requirements and obligations for caregivers, but also provides some suggestions and resources and support. So some really great tools, and all of these are something that we thought would be important to leverage. So if you could turn to the next slide, please. And that's what the third prong of SB 245 tries to do. So the third prong of SB 245 asks that this healthy sexual development work group that CDSS convened take the learnings and expertise that they gleaned over the course of their year and create a standardized curriculum that can be used with caseworkers and foster caregivers to address some of the key components that people said we need help, we need training in. So it would cover the basics on the rights and responsibilities. What are the rights of foster youth in these areas, and what are the responsibilities of the caregiver and social worker to ensure these rights are met? It would provide practice strategies. How do we open up conversations with youth about these issues? What are effective trauma-informed methods that will help us support the youth that we're working with? And then basic information on sexual health. What we discovered is not all of us are up to date on the most current methods of contraception and the options available. So what is the essential information that child welfare personnel need to know in the area of sexual health around methods of contraception, risk factors, including risk factors related to sexual assault, sex trafficking? What do we need to know? What do we need to be looking out for? So the third prong says let's leverage that wonderful work that the California Department of Social Services did and ask them to create a standardized curriculum. Next slide, please. And for this next section, I'm going to pass it back to Amy Lemley to introduce the final provision of the bill.
Well, the final provision is a curriculum on a shelf. Doesn't do much good. But the next step in the process is making that comprehensive statewide curriculum available to the people who are interfacing with young people. And so that's really what the goal of SB 245 is. For social workers, licensed foster parents, relative caregivers, group home personnel, and personnel working for foster family agencies. So essentially, including resource families, now that we've made that change with the continuum of care, and judges. And so, including this as a topic in the training that these individuals receive so that they can have the best understanding possible, feel equipped and ready for when the moment is right to have these kind of conversations, to know what the latest science is around reproductive health, and just to feel confident that this is a topic in their scope of practice, that they feel prepared to address with young people, and that they can kind of engage in confidently, so that we can go back to that slide, maybe in 5 years, and all of those questions will be questions that can be readily answered by every child welfare professional that's interfacing with young people in the field. So that is the fourth provision. And as it says on the slide, for social workers, this is training is a 4A reimbursable activity, not for each of those categories of individuals. But a lot of this is modeled similarly to the psychotropic medication legislation, where it's another example of an issue that has surfaced, that's become relevant, that we're understanding that child welfare personnel need more support, more information about. So that's really the fourth provision. So we've gotten a lot of great comments and great questions, and before we go to them, and we're kind of wrapping up the hour, we really want to take a moment to talk about the legislative timeline for SB 245. And so, this is a state bill. It will be heard in its policy committee and then its fiscal committee. If we are successful in the Senate, it would go over onto the Assembly side. And you can see from the slide, it would be heard in the Human Services Committee and then again a fiscal committee. And then if we have the good fortune to get that far, it would move on to the governor. So we really have between now and October 15th. And in some ways, as you hear kind of what's being presented, it seems like a no-brainer, like who's going to disagree with this? But the truth is, we are in very complex political and financial times. There's a lot of noise in Sacramento. There's so many competing interests. I don't think anyone would ever stand and say, I disagree. I think foster youth shouldn't have access to reproductive health. But the question is this going to be made a priority in our current legislative session? Can we find a way collectively to fight through the noise and to say, yes, 2017 is the year when the reproductive health of foster youth is going to be a priority? Now, this bill in and of itself is not a magic wand. It's not going to make everything great tomorrow. But it's a very important first step. It's a first step we should have taken 5 or 7 years ago. But it is a first step we have to take this year. Because if we don't take the first step, we can't take the second step. So, this is my very pleading way of reaching out to you and saying, we need your help. Legislation doesn't get over the finish line because of 3 sponsor organizations. We're just, groups that are thinking and caring about this. It's only if we truly form a strong statewide coalition of people who are willing to put time and energy into this legislation will it be a success. And that's what we need you to do, whether you're a nonprofit entity, whether you're a public agency, whether you're an individual foster youth, a caregiver, a group home. There really is a role for everyone to make this legislation successful. And so the kind of first step in the process is that Senate Human Services Committee. The first thing you can do is to support the legislation by submitting a support letter. So in the follow-up to this web seminar, we will send a template in the follow-up email. If you have time, we encourage you to write a long, wonderful letter detailing how important this issue is to your organization and send it in. If you don't have time, draw on that sample support letter, put it on your letterhead, and that counts too. I think some people think, do these letters really make a difference? Well, they actually do. They send a message that people in the community, people in elected officials' constituencies are thinking and caring about this issue. So that's the first thing you can do is send a support letter and send it to the email on your screen. We'll be collecting them and forwarding them all to the community consultants so they can be listed in the formal analysis. And the second is this will likely be heard in March. The exact hearing date hasn't been set. But we really invite you to come to that hearing and speak your truth. It's a very diverse group of people we have on the web seminar today. Over 180 people registered, over 112 people are on it, and you come from all walks of life. You have important points of view to share. This is democracy in action. If our elected officials don't hear from you and don't understand why you're taking the time to care and think about this, then they can't adjust kind of their decisions accordingly. So we really invite you to come to that March committee hearing and help the elected officials know why this is important to you. And then work with us over the course between now and hopefully, if we're fortunate enough to make it all the way until the governor's desk, all the way until October. And we're going to reach out and find legislators in your district that you can reach out to specifically to help tell the story and help your legislator understand why this is important. No, it's not the repeal of the Affordable Care Act, but it is very, very important. Just because it's not the #1 kind of federal threat doesn't mean it's something that we should say we're going to wait until next year or wait until the future. This is a reasonable bill that leverages the existing structure for comprehensive sexual health and builds on that. So again, it's an important first step forward and one that we're going to have to put a lot of energy and effort into making happen. So we really hope you'll be involved over the spring and over the summer. So with that, I want to address some of these great questions we've been getting from all different kinds of people, and I will pose them to different members in the that presented. And the first one is to you, Rebecca. The question is, I'm interested in learning more about the specific curriculum currently being implemented that meet SB 245 requirements. Do they have names or websites that I could access to learn more?
Yeah, that's a great question. There actually is a governmental organization called the Adolescent Sexual Health Working Group. It's a coalition of several Department of Public Health, Department of Education, and several private organizations. And when the California Healthy Youth Act went into effect, they took it upon themselves to review all of some of the top curricula available and in use in California and compare and assess whether they comply with the California Healthy Youth Act. And so if you Google ASHWG.org, so that's Adolescent Sexual Health Working Group.org, they do have a wonderful document now available that summarizes their review of the most popular and frequently used curricula that comply with the new requirements of the law, and they made sure that some of those, the ones that they reviewed, are ones that are available for free. Some are available for purchase.
Thank you, Rebecca. This is a question and a comment from Jaime Munoz from Orange County, and Orange County was one of the 6 really wonderful counties that participated in the Institute. I think a lot of credit for this bill, last year's budget proposal, and this whole kind of movement generally goes back to those counties who stepped forward and said, despite no money and no extra time, we're going to try and do something about this. So Jaime wrote in, I'm glad it includes judges too for training. So SB 245 can require this, ? And yes, so this would require this to be a topic for trainings for judges. There's another question, and there's so many of them, it's kind of hard to find them as I go back and forth. And this is for you, Rebecca, wanting to confirm that the comprehensive sexual health education does address the needs of LGBTQ young people, given their disproportionate representation in the foster care system. Is that the case? Is that going to be relevant for them?
Yeah, that's a great question. So the requirements of the California Healthy Youth Act are that it affirmatively address in a affirmative way the needs of all youth, including youth of all sexual orientations, and that the curricula use examples that reflect the array of relationships that may be out there. So it's a huge step in that area.
Great. There's a number of comments from Douglas Braun Harvey out of LA County, and really highlighting and wanting people to know, and we want you all to know as well, Los Angeles County, again, a participant in the Institute, and long before that, really a statewide and probably national leader in recognizing the importance of ensuring access to reproductive health, that they have implemented a caseworker training for several thousand of their social workers already. That's really beginning to, chip away at this. And so this is an example of a county stepping forward to ensure that, that this happens for youth in their county. Next one, I'll turn back to you, Rebecca, for this, or Sue, if you'd like to answer it. What provisions are built in for those with mental health and developmental disabilities?
I'm afraid I missed the question. The sound went out.
I think what provisions are built in for students who have mental health or developmental disabilities, so that perhaps the comprehensive sexual health content, reaches them and it's meaningful for them. And does it provide for youth who are transgender? I'll make it a 2-part question there.
So I can address the comprehensive sexual health education component, and then Sue, if there's other stuff you want to add, please please do. Another requirement of California law is that the curricula are accessible and available and address students with disabilities, and that's disabilities of all kinds, and so they're required to adapt the curricula so that it is accessible to youth, whatever the disability may be. And in the same way I alluded to the requirement to address in a positive way youth of all sexual orientations. There's also a specific provision that requires discussion and addressing issues of gender identity, gender spectrum, and talking about and being inclusive of all gender identities. If folks want to see the specific criteria requirements, they're listed in Education Code 51933. So you can see the exact language about how this tries to address the full range of issues that we've just mentioned.
Great. Several people have asked if the PowerPoint will be available. We will send it out along with the recording to everyone who registered for the web seminar. Also, Jaime makes a very good point, which the Urban Institute's mobility from poverty has galvanized around this issue, although not exclusive to foster youth. It's a very interesting framing of this issue in terms of family formation as a strategy for poverty prevention. And you know, it's yet another way of looking at this issue that lets go of the, you know, any type of judgment or kind of personal belief around whether a young person should or should not be having sex or should not be a young parent, but really looking about how to think about it as an anti-poverty strategy. So it's very interesting. Well, we're at 11 o'clock now, and I just want to take one last moment to thank you all for being on today's web seminar. Thank you, Alexis, Sue, and Rebecca, for being on it as well. And we look forward to working with everyone over the course of the spring and the summer on SB 245. This concludes today's webinar.